Today, our focus is on transgender health. My name is Cecilia Patino-Sutton, and I co-lead two educational cores within the Institute, Workforce Development and the K Training Program. And I also lead the Masters in Clinical Translational Research under Preventive Medicine. So if anyone in the audience is interested in developing a course or a seminar related to clinical translational research or getting trained in clinical translational research, please do not hesitate to contact me or anyone on our team. So within our training programs, as a training program, we're really committed to training a broad spectrum of clinical translational researchers and a workforce that is aligned with the research diverse populations of Los Angeles and beyond to better address the health needs of our communities. The diversity of the clinical translational research workforce is one of our top priorities, and we've made a lot of deliberate changes into our program that have impacted who we train and the research they conduct. Our overall goal is to decrease the time to improving the health of diverse populations, a goal that aligns really well with the work of our invited guest, Lindsay Lawrence. Lindsay Lawrence is our guest speaker for today, and it's with great pleasure that I introduce you to her, who is kicking off the 11th year Career Development Seminar Series in our Institute. Lindsay Lawrence is a process architect and a performance improvement analyst at Keck Medicine of USC and has been part of Keck for the past 12 years. She dedicates much of her time in developing and implementing educational and outreach opportunities to provide optimal patient-centered care to the LGBTQ patients and their families by creating an atmosphere where we can all comfortably share who we are with our providers, as well as assuring that our LGBTQ staff feels valued. Importantly, she's also the chair of the Keck Pride Committee at USC. Lindsay, thank you so much for coming. And we're really looking forward to hearing about your work related to transgender health today. Thank you.
Thank you. It is my pleasure to be here. I'm so thrilled anytime that I get to talk to such a broad, diverse group of, some of you are practitioners, researchers, maybe just interested parties, but let me go ahead and cue up my slides so we can make sure this is working. Yes, we're good. It looks like everything is up. This training is accredited for CME and CEU credit if that's applicable to any of the attendees today. We just ask that you make sure that your name is properly reflected so that the records can show that you were here. A little bit of logistics. This is a webinar format, so you don't have to worry about being muted. You already are. If you do have any questions as I go through, please put them in the chat. Cecilia will be monitoring the chat and can flag anything that needs a little bit more exploration during the presentation, and we will also have time at the end. We are going to talk more about pronouns a little later, but if you're comfortable adding in general as a Zoom practice, again, I know things are a little bit different in a Zoom webinar format, but as you're commenting or chatting, if you rename yourself to include your pronouns as part of your Zoom username, that's very helpful for me and just as a good practice that we will talk about more. I am going to talk a little bit about our Keck Pride work, but just always flagging, you do not have to be a Keck Medicine of USC employee to join the email distribution list. And if you're interested, you can email keckpride@med.usc.edu to join. And then you will get a PDF of the slides today or after the training. This is going to be a lot of information that we're going to go over. Sometimes it might get a little overwhelming, so don't worry, you'll get all the information and you'll get all the resources. So thank you, Cecilia, for that incredible introduction. I have been at Keck essentially since USC took over ownership back in 2009. And I like to say my full-time work, the job that they pay me to do is as a process architect. So I'm really looking for where are the areas in our health system that we can improve to provide that better care to our patients and to the staff. And that really kind of feeds over into my work as the creator and chair of the Keck Pride Committee, because this is just something that I'm so passionate about. I've been out as a bisexual queer woman for a very long time now, and I have been speaking and teaching about LGBTQ identity issues for about 20 years now, and probably in the past, I would say 5 or 6 years, really focusing on LGBTQ health in particular. So at Keck, I've provided over 1,000 hours of training across the health system, in addition to local, state, and national conferences. So this is something, if you get me started, I could talk about this all day and all night. So I'm incredibly excited to be talking with you today. And I mentioned our Keck Pride Committee, and this really came about back in 2015, and we've built over the years to be that resource at Keck Medicine of USC for kind of anything LGBTQ related. So what are we doing for our patients? What are we doing for our staff? And what are we doing for the community? I'll talk a little bit more about the Healthcare Quality Index on the next slide, but I just love this picture of, again, when we could be with people out into the world, where we had a really beautiful showing at the LA Pride Parade back in 2019. So we hope that we will be able to do more things like that in the future. So the Healthcare Quality Index, this is out of the Human Rights Campaign Foundation, which is the nation's largest LGBTQ civil rights organization. And they created this national LGBTQ benchmarking tool that hospitals and healthcare facilities can use to really benchmark themselves and say, am I implementing best practices? What are resources out there that I can incorporate? And they look at 4 main different areas. They look at non-discrimination and staff training opportunities. So kind of this included, again, patient services and support. What are we doing for our employees, and how are we interacting with the community? So I'm really proud to say that after we started participating, we have received, so Keck Medicine of USC, all 3 of our hospitals. So there's Keck Hospital of USC, which is our primary surgical hospital, tertiary and quaternary care. We've got USC Norris Cancer Hospital, and then Verdugo Hills Hospital in Glendale, which is our community hospital. So all of them have been designated as national leaders in LGBTQ healthcare equality, again, based on these very detailed criteria that the Healthcare Quality Index puts out every year. And kind of how that feeds into the discussion today is because they're focusing more and more on what hospitals and healthcare facilities are doing for the transgender community, and how are we working to improve transgender health. So that kind of tipped off these very focused transgender health trainings that have previously been targeted more towards frontline providers, but we're expanding it more to kind of anybody in the healthcare field who wants to learn more. So today I'm going to talk about, again, a lot of different things. We're going to start by just going into some terms and definitions around gender identity. I'll go into some health disparities in the transgender community. The bulk of what I love to talk about is what are the ways in which we can create that welcoming, affirming environment, and how are we communicating in a way that's welcoming and affirming. And I'll have a little bit of information about resources for transgender health at Keck Medicine. This is my disclosure. I have nothing to disclose. So let's dive into terms and definitions. And for all of my trainings that I do, I always start with this slide because there can still be that question sometimes of why are we talking about sexual orientation and gender identity? And everybody has those 2 things, right? Today we're going to be focusing on the gender identity piece, but they have been linked, socially, culturally, but the way that we talk about it changes and terminology varies. So while I am going to go into terms and definitions, it's not the end all be all of what you need to know, right? It depends on the time, the presentations that I was doing 20 years ago, I look back on those now and I'm like, ooh, I would adjust that a little bit. We're not saying the same things. The context that we're using, the environment, the terms that people use with each other and their friends and their community might not be the terms that they're using with their healthcare provider. So just in general, understanding how someone self-defines themselves, how they see their sexual orientation, or again, here we're focusing on gender identity. That's the really important key part to being able to deliver that compassionate care or be able to create that research environment, right, where we can learn more about this population. So I always emphasize, like I mentioned, we talk about sexual orientation and gender identity together for a lot of reasons, but they are two separate and distinct concepts. So someone's sexual orientation, you know, all of those ways that we can be attracted to other people, fall in love with other people, be in relationships with other people, that's one thing. Completely separate and different from your gender identity, which is your own sense of feeling like a man, you know, feeling like a woman, not identifying with those options, which we're going to get into. So just keep that in mind as we move forward. I also always like to emphasize coming at this through a cultural humility lens or using a cultural humility framework, because everything that we're going to talk about today, like every slide could be its own 1-hour presentation, right? Gender is complex. We have a lot to cover. There's a lot to unpack, a lot to unlearn. It can feel uncomfortable at times, but I love this framework from these two primary care physicians who really emphasize this lifelong process of learning, you know, being able to do the hard work of self-reflection, self-critique, you know, what have I said? What have I done? What is currently in my practice that could be potentially causing harm or not providing the optimal care that I want to provide? And how can I approach this from a humble, authentic place of learning? So again, I really, really want to emphasize this as a way to take this in moving forward. So I think it can be really helpful to think about gender as having 3 dimensions. So gender assignment, this is what I think a lot of us think about when we think of gender. This is kind of how we learned growing up that your gender is what you were assigned at birth. You know, it's what was on your birth certificate. Did your parents send out a baby announcement saying it's a boy, it's a girl? You know, those designations were made for us. You know, we don't come out of the womb having a conversation about our gender identity, you know. This is something that someone says about us, but we don't necessarily have input into that at the time. But that's really, for a lot of people, that's the start and the stop of what we learn about gender. But like I mentioned, gender identity, which is the most important component, right? That's your sense of your own gender. And again, like I mentioned, people could identify as men, women, non-binary, other identities, which we will get into. And then of course, because gender identity is so internal, it's so personal, none of us are mind readers. I always say, if you are, please put that in the chat because we need to know that. But in general, we can't just look at somebody and assume what their gender is. So how do we communicate that to other people, whether consciously or subconsciously? And that's our gender expression, right? Those are all of those ways that are coded as masculine, feminine, androgynous. You know, it's everything. It's the clothes that you wear, it's your mannerisms, the way you do your hair, it's the profession that you're in, all of these things that have somehow been coded as being associated with gender. Some things which you're consciously trying to influence and some of those which you are not. So when we start to talk about the transgender community or people who are transgender, that really just means that their gender identity, how they feel about themselves, is different from what was assigned to them without their consent, right? Without their input. So transgender, we love our umbrella terms. So it's also its own identity, but also an umbrella term for many different gender identity terms, just outside of male or female. You will see it abbreviated as trans. I will abbreviate it as trans. And it's not just transgender and everyone else, right? So if trans means different than, cis means same as. So someone who is cisgender describes someone, their gender identity and what they were assigned at birth correspond or align. So that is the majority of the population, right? I'm going to make an assumption that many of you might have learned a new potential identity term for yourself. But most important takeaway when we're thinking of people, when we're interacting with people, to do that based on their gender identity, not what's in between their legs, not what was on some piece of paper that they got when they were born. It's about who they are as a person. So some different transgender identity terms that you will see and interact with, right? So someone who's a trans woman, so this is a woman who was assigned male at birth. She identifies as a woman, is going to take steps to transition and live her life the way that she sees fit. So transgender man, someone who was assigned female at birth, identifies as a man, is going to take steps to transition and live his life as the way that he sees fit. And you'll see the asterisks next to these acronym terms, right? M to F as being male to female, or F to M as being female to male. Primarily, you're seeing these terms more in like medical research. So again, if you're going to the literature, if you're looking at electronic health records, for example, the community is kind of moving away from those M to F, F to M terms, although some people do identify with those, right? But generally speaking, not as commonly used as self-descriptors, more likely to be encountered if you're looking at, again, the medical research or something like that. And these are not the only terms, right? Gender is a spectrum, gender is complex. There's all sorts of different ways that people can identify themselves as trans feminine, trans masculine, demigirl, demiguy, you know, it's like the limit does not exist. So many different terms exist. There's terms differently used in cultural contexts and things like that. So again, as a researcher, as a healthcare provider, as a community member, you don't have to know every term that exists, because I don't even think that would be possible. You just have to be open to learning about how people define themselves. And I mentioned, you know, this process of going through a transition journey, being on a gender affirmation journey. And when we talk about transitioning, it's really this overarching process where, you know, you come to recognize your own identity, you affirm your identity, and you want to share that with other people. You want to express it to others. So there's a lot of different potential components that can be a part of someone's gender transition or gender affirmation journey, which we'll go more into depth in the next slide. But here, the big takeaway is that I think for a lot of people, there's this cultural narrative that when you find out someone is transgender, the first question is, have they had the surgery, or do they want the surgery? And what the surgery is means different things to different people. But generally speaking, it's this idea that unless there's been some sort of surgical intervention, that a person cannot be authentically trans, or, you know, really trans, or whatever. But when you really unpack that, there is no finish line, right? There's no one road that says, okay, once you get to this point, then you're transgender, then we can interact with you as the gender that you say that you are. There's no one size fits all approach. People can go at whatever pace they can or want to, and, you know, depending on what they want to achieve. So again, taking that, we're going to talk a lot about challenging assumptions, kind of unpacking these beliefs that we have. And that's a big one of them, right? That there's no one way to be transgender. There's no finish line that people have to get to. But for many transgender people, some general aspects of a gender transition journey or affirming someone's gender, you know, can include some personal and social aspects, like choosing a name that better suits you, wearing clothes that better suit you and reflect your gender identity, and communicating with other people, right? Please use my name, please use my pronouns. The gold side, this legal and medical side, this has this big caveat at the bottom, because everything that we talk about with legal transition or medical transition or surgical transition, those all depend on what your access looks like. It all depends on where you live. Is it even legal for you to do these things? How much does it cost? You know, are you even able to find providers and services for you? So in many cases, transgender people will change their legal documents, find a provider to take gender affirming hormones, potentially seek out various medical or surgical procedures. But again, the fact that the access to those things is so different depending on where you are, that can't be our criteria, or again, that finish line of this is what you need to do in order for us as people, as a healthcare system, as society, to see you as authentic. And we've kind of, you know, the way things have been presented, it's been a little binary right now, right? I think for a lot of us, and I will say myself included, we're raised to think of sex or gender as binary, as only two options, as these like fixed categories that have very specific characteristics that are fixed and immutable. You know, we learn about being female or male, man or woman, boy or girl. But again, when you really start to unpack that, look into the research, look into the history, it's like nature doesn't really have a lot of binaries. That's really not how things work, and that's not how people work. So even when you look at these ideas of, you know, someone's sex assigned at birth or their birth sex, people are intersex, which we'll talk about. When you look at gender identity, people are not just men or women. You can be non-binary, which we'll talk about. And here, the big takeaway is that these are not new or unique concepts, you know, to this time and place. People who are outside of the gender binary, outside of this idea of male or female, men or women, have been present throughout world history. You know, they've existed as long as people have existed. Maybe not using these specific terms, but they've existed in the world. And the United States is actually a little behind as far as legal recognition for intersex or non-binary identities. There are several countries that recognize more than two options. So I'm going to go over these again pretty quickly. So when we're thinking about people who are intersex, that really is just another umbrella term. I told you we love our umbrella terms for a variety of natural human variation that exists when you're looking at differences in sex traits or reproductive anatomy. And I just really loved this quote, you know, being intersex, it's a socially constructed category that reflects real biological variation. So there is no one set of criteria or one standard in place for what it means to be intersex, but statistics that you'll see most often quoted are this like 1.7% of babies, 1 in 100 babies, that different from just like the standard general idea of being male or female. But when you start looking into, you know, genitals, hormone levels, internal anatomy, chromosomes, right? There's not just XX, there are XY. There's, I think, like 5 or 6 different combinations. There's so many ways that people's bodies just do not fit this constructed idea of a binary. So when you're looking in the medical research, you might see some more of these outdated terms like hermaphrodite, people having ambiguous genitalia, or even more recently, disorders or differences in sex development. The community prefers just intersex. Non-binary, so when we get to the gender identity aspect, non-binary really just means someone whose gender identity just doesn't fit into that binary idea of men or women. So like I talked about, there are many transgender people who do fit into the binary, right? They were assigned one thing and they identify as this binary gender option. But for many people, they're saying that just doesn't really fit me. And again, this is both a term, a gender identity term, and an umbrella term that can fit a lot of different ways for people to describe themselves. Very important to know, in California, the Gender Recognition Act, this went into effect, I believe, in 2019, where now it's not just M or F as a driver's license option. You can go to the DMV and self-attest that we now have an X option to recognize and affirm people with non-binary identities. So again, as healthcare practitioners, as researchers, you know, wherever we are in the system, knowing that legally Californians, and there are several other states too, will have that designation on their identity documents, and we need to be able to record, recognize, and affirm that. You will see a lot of different types of non-binary identity terms, right? People might identify as gender queer, gender fluid, gender nonconforming, agender, bigender. There's so many different terms to kind of fall under this non-binary umbrella. And again, it's not important to know every term that's out there, but to be open to understanding where that comes from. I saw this last summer and just really loved it. This came from the Trevor Project, which primarily does a lot of work with young people and suicide prevention. But this idea of, some people say that gender looks like this. You've got blue is for boys, pink is for girls. They're each their little blob. Others say that gender looks more like a spectrum. You've still got your blue and pink, but then in the middle, there's like these fun purples. But in actuality, gender often looks a lot like this, this beautiful spectrum of color. There's not a line, there's not labels, and all of them look incredible and vibrant and beautiful. So I just saw that and I loved it and immediately stole it and added to my slides. And, like I said at the beginning, we're not talking a lot about sexual orientation in this presentation, and I'm not going to read these terms one by one, but these are common sexual orientation terms, right? And the takeaway here, going back to that very first slide of sexual orientations here, gender identities here, because they are two separate and distinct things, transgender people can identify with any sexual orientation that exists. A transgender woman, she could be attracted to other women and identify as a lesbian. A non-binary person could not be attracted to anybody, identify as asexual, be attracted to multiple genders, identify as bisexual or pansexual. Like, again, they can have attractions to anyone and identify with any label. So this I put kind of at the end of this definition section because, again, you hear this acronym of LGBTQ, right? And like I said, it's a very large community that represents a lot of different identities, and sometimes it can get a little confusing as to which population you're talking about, right? Because we have LGB, lesbian, gay, bisexual. Those are all sexual orientation terms. Then we take a hard pivot to the T, which is transgender, a gender identity umbrella term, and that's really what we're going to focus on today. More and more, you're seeing the Q added, which again is another umbrella term for just people who don't fit into being straight, don't fit into being cisgender, which we talked about. So it's kind of a little bit of both, a little bit of everything. And then you'll see LGBTQ+, accommodating a lot of other identities. You'll see LGBTQIA, which includes intersex and asexual people. So again, it's a very all-encompassing acronym, but sometimes you have to be very specific with what population you are talking about or researching or treating. Little bit of language just before we exit this section, just because language changes so much, right? And so some of these outdated terms on the left have either been used fairly recently or kind of went out of favor several years ago. But again, when you're talking about someone who's transgender, these are adjectives, right? You're always describing a person. So you are not treating a group of transgenders. You're always talking about people, so a transgender person, a transgender man or woman. This idea of someone being a biological man or woman, being born a man, or being a natal male or female, again, moving away from those ideas that your sex or gender can be tied to these specific markers and moving more toward this idea that you were assigned that way, based on a set of this socially constructed criteria. You're assigned male at birth, you're assigned female at birth. And again, that really feeds into this next one about people having a sex change or sex reassignment surgery. It's more about gender affirmation or gender confirmation. And these last two, legal name and preferred pronouns, if you go back to my slides from a year ago, you'll see some of this. And again, the community is really wonderful about diving in and saying, wait a second, is this really what we want to be saying? Because someone's legal name, describing it, because that gives it, someone's legal name gives it an air of authenticity, of reality, so you might use a certain name, but your legal name is your real name. Well, for many transgender people, which we'll talk about, it's very difficult to change your name legally or have your name reflected on your documents. So talking about an administrative name or name on legal documents that has less of a kind of a gut punch. And this idea of preferred name and preferred pronouns, this was commonly used language for a very long time. But again, that has the connotation that it's a choice. You know, I might prefer balsamic vinaigrette, but I'll eat, you know, something else. This idea of a preference that you could change. But no, this is someone's name that they use. These are someone's pronouns. And again, we all have a name. We all have pronouns. So getting away from that preferred language. But of course, like I said, this changes all the time. Most important to use what the other person is comfortable with. So that's a lot, right? That's a lot. I want to make sure if there's any questions. Let me check. Okay. Can you comment on the role of language and non-binary identities? Languages such as Spanish are gendered and the gender neutral term is in fact male. Yes. I will say, again, much of my reading and research is on English speaking populations, but there are movements, and again, I only primarily know about Spanish, to create a more gender neutral option. So you'll hear Latinx, but then the native speaking community is moving more towards having an E on the end of things. So not having this kind of male default in grammar, but having a more neutral way of describing people or concepts as using E. So I'm not going to pretend to be an expert on that, but I think it's a really interesting area for people to look into, especially if they're working closely with Spanish-speaking communities. So thank you for that. So I'm going to go a little bit into kind of population health, health disparities. I always have to kind of gird myself because this is the most depressing part of the presentation. Spoiler alert. Okay. So first, to kind of think about the LGBTQ population as a whole, right? And this gets right at the meat of what I'm going to talk about for the transgender population. Is it's hard to estimate. It's hard to estimate the LGBTQ population. It's hard to estimate the transgender population. There are different data collection methods out there. There's different surveys used. And then, so there's that, right? There's just kind of the messiness of the data. And then you get to kind of the social and cultural aspects of things where the older generation is not as comfortable even publicly identifying themselves as being identifying as LGBTQ, even on a survey, you know, even it might be anonymous, but just having that out there, not as comfortable putting that into the world. The younger generation, generally speaking, more comfortable with identities outside of that binary, right? So the binary of you're gay or you're straight, the binary of you're a man or a woman, kind of getting into those and really saying, nah, binaries are not for me. And then also the LGBTQ population and the transgender population in particular, just more racially, ethnically diverse than overall. So when we get to thinking or looking specifically at the transgender population, again, this is hard to estimate. There's no national population-based survey that collects gender identity data. If you're looking at the 2020 census, you're not going to find it. The only options were male or female. No way to capture if someone is transgender, if someone is non-binary. So the statistic that you'll see on the right is the most recent often cited statistic from the USC Williams Institute. And again, there's no national level data, so they were kind of aggregating state level surveys, mixing it in with a little bit of CDC, a behavioral research survey, and coming out with this number of about 0.5% of adults, 0.7% of younger adults identifying as transgender. But who knows, right? It's really hard to accurately assess the transgender population there's so many different ways to collect that data, to look at it, but it's important to do. It's important to continue to get this on surveys to improve the data collection, because this was a quote from a non-binary person who's trying to fill out the census. If you're not counted, you don't count. And so this breakdown of kind of who makes up the transgender population, this is from the 2015 National US Transgender Survey, which I'll refer to later in the presentation as well. This was, again, about 28,000 respondents, age range, again, adults largely from 18 to 64, so not a lot of representation from older transgender people. So when they looked at sexual orientation, about half of the respondents identified, again, outside of that binary. So they identified as bisexual, queer, pansexual, a lot of these sexual orientation terms that don't say I'm only attracted to one gender. When they looked at gender identity, it was pretty evenly split, right? When you look at it, about 30-ish% were transgender women, 30-ish% transgender men, the largest percentage non-binary, so identifying as transgender and non-binary, and then that little 3% of other. So again, very diverse, complex population. And I always want to emphasize this idea of intersectionality. And again, I trust that a lot of researchers have familiarized themselves with this concept. And again, really encourage looking at the original research from Kimberly Crenshaw. But when we're talking about transgender people, they're in every group you can basically think of, right? So if you are doing research, or if you are treating people of a specific demographic, you will have transgender patients, or you will have transgender members of that group. So anything that you're doing, if you're not including transgender people, you're leaving out a pretty substantial group. And of course, thinking about the systems that impact people that you're working with, right? So transgender people are not just dealing with ideas of transphobia or sexism, they're also impacted by all of these different systems out there, depending on what other groups they're a part of. And we'll get into that intersectionality a little bit more when we get into health disparities, of course. This slide is really population health 101, right? Populations that experience identity-based discrimination, stigma, trauma, that's stressful, both on a chronic and acute level. That is going to impact your health. It's going to impact your mental health, your physical health, your access to care is going to impact your health. And that's really what we see leading to these health disparities and inequities. It's not anything necessarily about, these diseases that only affect this type of population. And I like to pause a little bit on health disparities, because again, this is one of those terms that gets thrown around so much more and more now. But when you're focusing on health disparities, this is from the CDC, it is that those preventable differences experienced by socially disadvantaged populations. And part of how that can look for the transgender community is with health insurance, right? So this kind of blurry image is from when California, back in 2013, ended exclusions in health insurance plans for transgender related care. So this is great, right? 2013, they're saying if you're an insurance plan sold in California, you can no longer legally exclude someone's care based on if it's related to a gender transition journey. Prior to 2013, completely legal and incredibly common. So even if you were employed, even if you did have access to healthcare, the odds were incredibly high that your insurance plan would have a very clear exclusion for any services related to transgender health, related to gender affirmation care. Fun fact, when I was doing a lot of deep diving into the very messy and weird world of health insurance, When USC Verdugo Hills became a part of our system, their insurance was not through the state, it was through, elsewhere, and it was governed by the federal law, which did not have that rule in place. So again, this was 2017, and the only insurance plan available for Verdugo employees had that exclusion. It's gone now, and now we have complete coverage for transgender healthcare through USC. But even back in 2017, that was an issue. So these are recent changes, but if you've gone your entire life without having accessible, affordable access to care, that's going to impact your health, right? From a few months ago, June 12th, 2020, the Trump administration removes non-discrimination protections for transgender people in healthcare. So if you are part of a group where the basis of your identity is like, sometimes you're covered, sometimes you're not, it can depend on, who's interpreting it and where you live and what your access is. Again, you're not going to have the same opportunities to achieve that level of optimal health that people whose identities are not being debated. Some barriers to care. This is one of those slides that unfortunately could be another hour-long presentation, but just some of the stats that came out of that transgender survey from 2015. 23% did not see a doctor within that past year, so the previous year filling out the survey, when they needed to because of the fear of how they were going to be treated based on their gender. A third reported healthcare discrimination in that previous year due to their gender identity. And when you look at lifetime experiences, that goes up to 70%. And healthcare discrimination can look a lot of different ways. It can look like not even being able to get through the door, people saying, we don't treat people like you. And it can range from, being treated roughly all the way up to being physically assaulted. Only 11%. So thinking back to that slide with the cardinal and gold, the legal barriers, 11% had their preferred name and gender. And again, here's this preferred language, but that came from the study on all of their IDs and records. But 68% reported that none of their IDs had that. So again, these huge barriers to even accessing what you need in, using the name and gender that you have. There's a lot on this slide about health disparities. I am not going to go word for word on this left-hand column of like all the different types of disparities that you're going to see, because really, and I encourage you, if you're working with specific populations, to do a deeper dive, but it's really anything that you can think of related to access to care, behavioral health issues, anything that is stress related, and anything that is affected by societal discrimination. You're going to see higher rates of health disparities in this community due to many factors, right? Some of which we've talked about. So not having that access to preventive care. Again, if you can't even get in the door, you're not going to get those preventive health screenings that you need to detect cancers, to detect, heart disease, things like that. If you do not have a provider that you feel comfortable with for these sensitive exams, again, you're not going to get PAPs, you're not going to get rectal exams. Transgender people, again, because there's a lot of legal discrimination, there's higher unemployment and underemployment, which leads to less access to health insurance and higher rates of poverty. And then general distrust of the medical system, right? This has not been a welcoming place historically for the transgender community. And so that combined with good old social stigma and discrimination, that's why you see so much of these higher rates of health disparities in the community. Going back to that intersectionality slide, of course, the highest rates are going to be seen in the multiple marginalized populations, right? So transgender people of color, lower income transgender people of color, that's where you're really going to see those health disparities exacerbated, because not only is, the discrimination based on gender identity. There's also, medical racism, there's the environmental factors. So I do want to show this slide for transgender people of color. So back in 2019, I mean, that's only less than 2 years ago, but the AMA made a statement declaring an epidemic of violence against the transgender community, particularly focused on physical danger faced by transgender people of color, particularly transgender women of color. So if you look at any of the statistics out there about transgender people getting murdered, again, based on their gender identity, based on who they are, it's going to be largely transgender women of color. And you see that also in HIV, you see that with like depression, anxiety. So again, these statistics were from that US transgender survey from 2015. 6.7% of the Black transgender respondents were living with HIV, much higher than that sample of transgender respondents, 20 times higher than the general rate of the US population of HIV infection. And then when you look at women in particular, then the number jumps even higher, right? So 19% of the Black transgender women were living with HIV, compared to 6.7 of just overall Black transgender respondents. And you see higher rates with Indigenous and Latina transgender women as well. When you ask about psychological distress, 41% of the Black transgender respondents reported that serious psychological distress in the month before the survey, which is so much higher than the 5% rate in the US population. Again, 45% of the Latinx respondents. So again, these cumulative effects of being part of a multiple marginalized population. And of course, transgender health disparities are caused and reinforced on multiple levels, right? So there's the systemic level, what's in our federal policy, what's excluded or included in healthcare coverage. At the community level, how are resources allocated? Do the transgender people have access to specific health programs targeted to their needs? At the institutional level, do we have trained providers who can provide this culturally competent care? Is there access to care? On the interpersonal level, experiences of overt discrimination or implicit bias, which we'll talk a little bit about. And then, of course, all of this has an impact on the person. So the intrapersonal level, internalized transphobia, thinking that I don't deserve to get this care, or, those feelings of negativity based on your own identity with a group. It's hard to talk about. But when we think about research, having that diverse research around transgender communities, around their health needs, can really help address those barriers at each level, right? The research, again, we're seeing the statistics on the slides. Research drives funding for programs. It drives policy and priorities, and it drives the type of care that people receive. And one of this, just like one example, is Medicare, right? Medicare, the largest health insurance for people 65 and up and disabled people. So they removed the transgender exclusions of care back in 2014. So then you would think that that would make it easier for people to access care. But there's no national determination of how this care should be approved. And when looking into this, CMS, Center for Medicare and Medicaid Services, they looked into this. They did an extremely thorough literature review, studies that I had not even heard of before, looked at evidence-based guidelines. They looked at landmark studies of transgender health, but they couldn't find what they needed on the precise patient population that they were looking at for 65 and above transgender Medicare beneficiaries. So even with all of that, even with what's available out there, the result was still increased barriers. It's a regional case-by-case basis to see what's going to get approved to be covered. So anytime it's like the luck of the draw, right? Again, it's where you live, who's reviewing your case. And the reason that they went to that decision was there was not enough high quality evidence to support their specific research question. So again, I just like, that's why I was so excited to talk to people who are involved in research, because when I'm talking to frontline providers, you know, it's always like, we've got to have the research to back all of this up. We need more information, just in general, at a huge population level basis, and also at smaller levels too. So, I mean, again, not going to read this quote, but it's like, CMS encourages robust studies. Like, yes, yes, please, we need more of it. There's such a lack of transgender health research out there. And this was literally just copied and pasted from this really great article that I found about advancing methods for US transgender health research, written by some of the biggest names in transgender health out there. And really, when we're looking at, you know, that question of how do we even estimate the transgender population and how do we measure and improve health outcomes, there's such a need for, you know, more collection of gender identity data, making sure that data is collected based on or using the two-step method, right? This is, and again, this is 2016. So there have been improvements since then, but making sure that you're recording someone's gender identity and also what they were assigned at birth, looking at how to look at health disparities by, you know, someone's gender status, their transgender status, using standardization of terminology, because like I said, there's so many different ways for people to describe themselves, but from a research perspective, how can you align what is out there so that you can compare, right? Making sure that you're involving the community, and I'm going to talk a little bit about that on the next slide. Whenever possible, of course, we want large sample sizes. We want longitudinal data. And then, of course, representation. Going back to that intersectionality slide, it's not enough just to do research, you know, on like white, well-off transgender population. We have to include more. So, of course, it's so critical to be patient-centered. And I know that was something when I looked at the Translational Science Institute website, there was a lot of information about keeping the patient at the center, but making sure that if you're doing research, if you're building studies, if you're doing anything around transgender health, that you are engaging the local community to help guide you and kind of like point you in certain directions. And I just love this idea of, you know, work with, not on. So again, I'm going to take, like, I got to take a little sip of water. That's a lot to take in. It's pretty, you know, heavy information. I want to see if there's any questions. You see some may have to drop off. Because like, that's a lot, right? It's like, oh, things are bad. And this community has been historically very mistreated by the healthcare system, but what can we do? And this is the part that I get so excited about. So how do we create that welcoming, inclusive environment? And a lot of it starts on the personal level, right? To challenge our assumptions, to be honest with ourselves about what's going on inside, you know, to really do that work of unpacking. What have I been taught? You know, going back to that slide about, hey, when I grew up, my mom taught me about boys and girls. You know, she did not talk about a gender spectrum or any of that. She didn't know. That's not how she learned things. So what have we been taught by our family, by our communities, you know, by the media, by the world that we live in? And what have we internalized? And what do we not want anymore? You know, right? What's serving us? What's not serving us? How do our day-to-day behaviors reinforce the system that we may say that we are trying to change? That cultural humility lens of continually reassessing our behaviors and ideas. This is not a, you know, oh, I went to one webinar and I got this. This is a lifelong learning and unlearning process. And what can we do to take action to understand and change?
Lindsay?
And, oh.
It's me, Cecilia. There's a question that's related to what you're talking right now, and I thought it was a good place to ask you. There's one of the participants that's asking if does Keck Medicine have a transgender program?
Oh, I was going to talk about that a little more at the end, but I can go ahead and say now the short answer is no, but the exciting answer is it's coming. So
That's
that is
great.
something that we have identified as a huge lack for us, right? We didn't even know what providers were providing what services and to whom. So that was kind of the weird silver lining of the COVID epidemic last summer, is that we had some time to kind of step back and say, let's actually really do this work to find out who's doing what and start to bring them together. So we've had some initial meetings. It's incredible to watch people say, oh, I've referred patients to you for years, but I've never actually met you like face to face on a Zoom. So we are so that was our first step, right? Is just who's doing what, who do we have? Our second step, identifying those providers and their clinic staff. So we want to make sure that before we go live with anything, people have gone through a training like this and understand how to communicate with people and why this is important. And then we can start including the community into what should this look like and what would make the most sense for you as a patient coming into our system, and then we'll launch. So we had a much tighter timeline with COVID and like the surge again in the vaccine that's pushed it back a little bit. We're still hoping to get back on track. I'm again hoping later this month or in March, but this is something that's happening. So it doesn't exist right now, but this is a huge opportunity for us. So I hope that, and I'll go over a little bit more of our foundational work kind of at the end. But this piece about language, like understanding your language, this is a huge part of our education with the clinic and the staff, because this is how we communicate with people, right? And one of the things that I love to talk about is kind of destigmatizing bias, because I think for a lot of people, they hear this term implicit bias, or they hear stereotypes and they're like, wait, I'm not a bad person. I'm not a biased person. I treat people equally. I'm a good person. So one of my many soapboxes is like, hey, we all have biases. Our brains are structured to have biases, use stereotypes, use assumptions, have preferences. We could not get through the world if we didn't do that. And when we think about healthcare, the research about biases, when we're making those snap decisions that we can't even think about on a conscious level, information overload, we kind of have to go by our gut, and there's a need for speed. And I was reading these studies and I'm like, yeah, hi, that's healthcare. That's our entire environment, is kind of pushing us to use our biases on a regular basis. So that's why it makes it so much more important for us to examine what they are. Because really, it's just these assumptions, right, that we have internalized about a group that we're not thinking about. It's outside of our conscious awareness. And it actually has a huge impact on our behavior towards other people. So when we think about potential assumptions related to gender and gender identity, men have penises, women have vaginas. Men are masculine, women are feminine. Even specifically thinking, oh, all transgender people want surgery, or they want some sort of surgical intervention. Now, none of these are true, right? Or like one size fits all. But I would wager that many of us have these at some level in our minds that we need to kind of override. And if we don't, the literature out there, again, it's small but growing, is that biases in healthcare are correlated with poor access to service, lower quality of care, and worse health outcomes. And I think it's interesting, this idea of implicit versus explicit bias, because people will say, well, what about what I'm saying or doing? Like, shouldn't we be more worried about the people who are explicitly doing and saying negative things about this population? But our implicit biases are what's more strongly associated with our real world behaviors. And they come out in a lot of little ways, which we'll go into, because even if you say, You know, again, I will treat everyone the same. I'm welcoming. I want to include the transgender community. Even if you're saying that you don't have these negative attitudes, if you haven't done the work to kind of unpack what's seeped into your brain wants to be helpful. Your brain is taking in all of this cultural information and you're not even aware of it. But if you're not kind of doing that work, that can have unintended negative effects of, you know, preconceived notions about who's going to adhere to treatment, poor communication, microaggressions, which we'll talk to, and none of that is good. So mostly I'm going to talk about language. At the end, I'll talk a little bit about institutional support, because I was a former English major, so I'm like, language, yay. I love talking about language because that's how we communicate with people, right? Written language, verbal language. Our language is what reflects what we think of as normal and natural. And so part of this process of unpacking our assumptions and avoiding potential negative interactions is to be very thoughtful about using gender neutral terms whenever possible. That this constant process of challenging your own assumptions. Because so much of our language is gendered, right? You know, we grow up learning, yes, sir, yes, ma'am. Like I was raised in the South, you said that or you got in trouble. We say ladies and gentlemen, boys and girls, hey guys, all of these things that are, you know, subtly or not so subtly gendered. But for all of those, there's always a gender neutral option, right? You're working with a person, a group of people, you know, welcome everybody. Hi, it's good to see everyone. Like, welcome folks. I always encourage people to get fancy with it. Like I would love people's staff meetings to start off of like, welcome esteemed colleagues. You know, I think there's so many ways and examples that people can think of how to use gender neutral terms until you know what that person or group of people wants. And families is a huge one, right? For every word describing a family member or a family role, there's always a gender neutral term that you can use before you make that space to have someone tell you. You know, so instead of asking about mother or father, asking about parents and guardians. Instead of asking about sons or daughters, you know, do you have children? You know, are there kids in the house? Whatever the question is, siblings instead of sister and brother, nibblings instead of nieces and nephews. I really love that one. And I like to take a little pause here because even with these little cute people on the screen, your brain was like, okay, I got this. Let me help you. Okay, I see pants. That's a man. You know, like pink dress. That's a girl. Your brain is trying to fit these little images into these preconceived categories, right? And even as a person who created this slide, who was writing about gender neutral terminology, my brain is like, oh, look at these two moms, you know, with their son. And then I had to be like, hey, Lindsay, like you don't actually know these people. I want to know where they all got haircuts in a pandemic, but like I don't actually know them or how they identify or who they are. So how can I refer to them even in my own brain in more neutral terminology? Relationships, such a big one, right? We ask about boyfriends or girlfriends, wives, husbands. Here, it's so important to create that gender neutral space of asking about a partner or a significant other, a spouse, a relationship, because even if we have those pieces of the puzzle, we might know a person's sexual orientation, we might know a person's gender identity, we might know both of those things and feel really confident in our assumptions, but it just doesn't mean you know what their relationships are with other people or the words that they prefer to use. And again, doing that quick assumption check, you know, when you're looking at these cute little people together, what was your brain trying to categorize them as? You know, were you assigning genders? Were you assigning relationship types? Did some look more like friends? Some look more like partners? You know, what was your brain trying to quickly tell you, and how can you override that if you're to speak about them or, you know, move forward in a conversation? because this is more for healthcare providers, this slide, but this idea of being a patient, you're so vulnerable, right? You're being asked to provide all sorts of very personal, intimate information. And so when a provider can ask open-ended, gender-neutral questions and normalize that, right? To not say, okay, I'm asking you because I have to know about you. This is just, I ask this of everybody. This may or may not pertain to you, but I don't want to make sure, like, I want to make sure that nothing falls through the cracks. So, I mean, it looks like this poor person is getting barraged, but just this idea of what do we need to know and how can we ask it in a way that's as open and inclusive as possible. So that's why I put my little starburst. These are for providers generally, but when you're thinking, if you're doing research with participants, with people, what kinds of questions are you asking them? Pronouns. I love talking about pronouns. I said it at the very beginning. I like to normalize people putting their pronouns in their Zoom names, in email signature. And pronouns are important because these are the words that we use when we're talking about someone and not using their name. So generally speaking, most women, of course, including transgender women, will use she, her, hers pronouns, right? Feminine pronouns. She's scheduled for a 9 a.m. appointment. Did you call her to confirm? Most men, of course, including trans men, will use masculine pronouns. He, him, his. He's running late. Can we push his appointment? I realized that using the running late example for the men is also stereotypical. And see, the brain is powerful. I was not even consciously aware of that. And then people of any gender, including some non-binary people, will use the singular they, which we're going to talk more about, but they, them, theirs. This is their first time here. They have a persistent cough. These are not the only pronouns out there. It's most important to just find out and use what the other person's comfortable with, or provide them an opportunity to tell you theirs, whether on a form or in a conversation, to provide yours and ask what theirs are. So this is one of those slides where it's like, if you take nothing else from the presentation, this is it, to love and embrace the singular they, because I feel like for many people, there's this gut reaction of, wait a second, that's not grammatically correct. I can't use they to refer to one person. But the short answer is, yes, you can. The longer answer is, it is grammatically correct. It's been used like that for hundreds of years. Shakespeare used it. It's in all the major dictionaries. It's in all the major professional language guidelines. It's in all the major electronic medical records. And it's important to get comfortable, like we mentioned on the previous slide. If somebody uses they, them, theirs as their personal gender pronouns, the more comfortable you are, the more able you are to use they and make them feel comfortable. We want that. It is great if you don't know someone's gender. You haven't met them yet. Maybe you haven't had a conversation with them about pronouns. You could make an assumption, but you could also just say they until you find out and use what pronoun they use moving forward. So it is great to kind of smooth over situations where you just don't know yet. You do not know that for a fact. And it's great for generic examples. This is another soapbox that I will gladly get on, because when we talk about generic people in generic professions, there's a lot of very gendered language that happens. I hear this all the time in healthcare. When people are talking about a generic doctor, they will say he. When people are talking about a generic nurse, they will say she. Just use they, because this is a great example of that implicit versus explicit bias. So I actually had this happen to me recently. I had to call a department, and the person said, okay, do you have a primary care physician? I said, yes. They said, okay, let him know, that you spoke to us. And I'm like, okay, I will let her know that we had this conversation. And if I had asked this person, oh, you said he, do you think that only doctors should only be men? I guarantee you they would have said no. I guarantee you they would have said, no, of course not. I think anybody can be a doctor. But the fact that it's so just easily coded into our brains that doctors are men, nurses are women, it reinforces that idea that we consciously do not agree with. So use they, it's great. And it just takes practice. So I encourage people to practice with your family, with your friends, with your colleagues, talking to your pet, whatever the situation is, just practice to get more comfortable using the singular they. Because it's important to use someone's name and pronouns all the time. Like I said before, everyone has a name, everyone has pronouns. So get comfortable being uncomfortable. Practice, practice, practice. I'm gonna like hammer that into the ground because you will make mistakes, right? So when you make a mistake, because you will, just correct yourself and move on. There's no need to make a huge production out of it. That's actually very counterproductive in building a relationship with another person. Even when you're talking about someone who's not in the room, right? Just correcting yourself, making that adjustment and moving forward. When you get corrected, not getting defensive or taking it personally, thanking them, for making sure that you have the right information, you're saying the right thing. And again, I encourage people with colleagues and others, just get in that habit of if you catch someone accidentally using the wrong, pronoun, misgendering somebody, making sure that they're getting it right. And again, this is more geared to providers, but can have applications in the research world of just listening, right? You could collect all the data you want. You could make sure that you have information on forms or that you're asking them. But if you're not actually taking it in and mirroring it back to them, they're not going to feel heard. And again, I had this experience recently with my doctor where she's asking me about an experience and I'm saying they to describe the person. They came over, they sat, closer than 6 feet. And she's like, okay, so when she came over, when she sat down, and I'm only saying they, and I left that appointment thinking she didn't hear me, like she didn't listen to me. We still have a great relationship. I don't want to not have her as my doctor, but I didn't feel heard. And so making sure that whatever information you're getting, that you're actively incorporating it and mirroring back to them, that's going to improve that trust and that treatment compliance at the end of the day. Microaggressions, another thing I love to talk about, because microaggressions are those things, those small things. Thinking about the healthcare discrimination slide when I talked about how some patients get physically assaulted or told we don't treat people like you. Again, if I were to poll this group, my assumption is that hopefully everybody here would say, I would never do that. I would not physically assault a transgender patient. I would not kick them out of my clinic, etc. But microaggressions are those little things that come out that have a harmful or discriminatory impact, whether we intend it or not. Because these little things that we say, again, without unpacking what's in our brain causing them to come out, they reinforce what we secretly think of as superior or inferior, or desirable or undesirable, what we've been taught as normal versus abnormal, what's included versus excluded, right? And so some examples of microaggressions pertaining to someone's gender identity, they can look like statements that invalidate someone's identity or experiences. That question of, have you had the surgery or are you going to have the surgery? This idea that, oh, well, if you're not going to medically transition, you're not really trans. Oh, I'm sorry, you told me your name, but I have this legal name here and I have to use that. This idea of, oh, sorry, I keep forgetting your preferred pronouns, even the idea that someone's pronouns are a choice, right? They can also look like good intentions. I see this a lot. Again, my assumption is that generally speaking, people are not trying to hurt others or to explicitly be negative. So some of these statements can seem like they're coming from a good place, or they can seem like they're intended as a compliment. But like this top one, right? Oh, I never would have known you were transgender. You're so pretty, or you look just like a real man. This idea that there's a good way to be and a wrong way to be, or a real way to be and a less authentic way to be. So these ideas of making sure that what you're saying is not actually having an unintended consequence. And this is important because microaggressions are a health issue. I like to use this example of thinking about wearing glasses. If you get one scratch on your lens, you're misgendered one time, or someone calls you by your dead name, your name that you no longer use and is actually very painful for you. One scratch, annoying, you can still get through the day and function. But if you're moving through the world and you're constantly hearing those microaggressions, you're constantly having your identity called into question, or you're being misgendered, or, again, not being called by your name, those scratches, they add up and they add up. And at some point, your lenses are so scratched, you physically can't see where you're going. You can't function in the world as the way that you should if there were no scratches there. So this cumulative effect of microaggressions, the more that people experience them, the more likely they are, of course, to report feeling depressed, anxious, which has an impact on physical health and has a huge impact on trust in their healthcare provider. And I think it's important to realize that this idea that we're talking about of unpacking your own biases, of challenging your biases, of changing your language and the way that you think about people and gender, it's hard. This is not easy work. There's a lot to untangle here. For a lot of us, these are concepts that we learned as a very small child and have been very foundational in the way that we think about things. So it's important to be rigorous and committed, but to hold that compassion for yourself and others. And so, realizing I don't have to be the expert, I just have to be open. When you get corrected or new information, I appreciate you telling me that. Like, oh, I hadn't thought about it that way before. Like, thanks. This is new to me. I want to learn more and seek out those learning opportunities. Because like I said before, mistakes will happen. None of us are perfect people. None of you, spoiler alert, are perfect people. Practice is not going to make perfect, but it will make you more comfortable and easily adapt to new information and new situations. And I think it's important to remember that, especially for the transgender population, coming into healthcare or healthcare research or whatever the situation is, there's a lot of potential fear and potential negative anticipation because they assume that something will happen. So when you make that mistake, that you will, a thoughtful apology can go a very long way. And I was actually participating or watching a patient panel a couple months ago where they had, different transgender patients talk about their experiences in healthcare. And one of the questions was like, what was a good experience that you had with it in healthcare? And the person said, I went to see my doctor and they accidentally called me by the wrong name, by my old name, and then immediately corrected themselves and apologized and then moved forward and used my proper name from there on out. And so this idea that it wasn't the fact that, they didn't come out thinking, oh, I just had a terrible experience with my doctor. They were, misgendered and they were called the wrong name. But the fact that the person said, I'm sorry, let me make sure I'm using the right one, and did that moving forward, they came out of that thinking, I just had a great experience with a provider that I can trust. A little bit about institutional support, because again, like going back to that slide where we've got so much information coming at us, our brains are so overloaded. We work in healthcare, which is its additional level of drama. How can institutions help us do the work that we need to do? And so that structural support can help take some of the weight off. It can help provide those reminders and reinforcements so that we can hardwire what we need to do. And so some of the ways that that can look like, at Keck, having a patient's gender pronouns on the banner bar. So when you go into a chart, there's like that reminder of, hey, I need to be thoughtful here. Adding pronouns to intake forms, which is very hit or miss depending on where you are. Do we have public signage about our inclusive policies? And again, this can look differently depending on where you are. At Keck Medicine, We just want to be very clear that all of our policies that include protected categories include sexual orientation and gender identity. This is good practice, but also California law. But a couple of years ago, we also looked at best practices and created policies specifically around the needs of our transgender and gender diverse patients. So I'm not going to go into those in this format, but just knowing that they're there and accessible. We do have a policy around interacting with transgender patients, which really boils down to like, don't be rude. And, our policy is that we're going to use your name and pronouns. We have a policy around equitable restroom access that just says you use the restroom based on your gender identity, not anything else. We're not in the business of supporting harassment. And we have information on if you have to place a patient in a room based on gender, you do that based on their gender identity. And we also updated our electronic medical record to include more robust sexual orientation and gender identity options. And I put a little bit more here again, because if you're doing research with electronic health record data, you want to make sure that you have the data, right? So a couple years ago, we implemented the ability to record gender identity and birth sex separately in Cerner. It's called stated sex, which is the most awkward terminology, and no one actually uses that. So I don't know where they got that, but it's hard coded and we can't change it. So stated sex, AKA gender identity. Within those options, there are also non-binary options to reflect the California state law. But so that's mandatory. That's anytime you have a new patient coming in, that information needs to be put in. We added more detailed options for sexual orientation and gender identity, kind of in this social history, sexual history section, but that is not always completed by every provider. But prior to 2018, it was like, are you lesbian, gay, bisexual, or transgender? Blah, what a nightmare. And then last summer, this is what I was so excited about. We added the ability to put a person's pronouns on the banner bar. We only have 3 options. Again, I know we talked about how those are not the only ones, but those will cover the vast majority of people. So a provider can select, between those 3 options. It'll go up on the banner bar. And if someone has a name that they use that's not their legal name, and again, this goes for anybody, right? If my dad goes into the hospital, he's not going to feel comfortable if you call him Robert, please call him Bob. So these steps to create an atmosphere that's more welcoming and inclusive for all patients, but our transgender patients in particular. And then I always end on this patient letter because it can get very cerebral, right? It can be like, okay, I gotta, use this term and I need to look in the chart here, et cetera. But this was a letter that we received from a patient that really gets at this is why we do what we do. So this was from Verdugo Hills, our community hospital. Not going to read this word for word, but it was from a transgender man who was recently into his transition journey, has a seizure disorder, so in and out of hospitals all the time, had some very negative experiences and became very afraid of getting care for his health condition. And so when he came to the emergency room at Verdugo, he wrote to us and said, they were sensitive to my needs. They used my pronouns. I felt safe when I was there. And I've been reading this letter for 2.5 years now. I get goosebumps every time. It's just like, that's how we want everybody to feel, right? I'm like at a baseline, like, oh, we used your pronouns. That should be baseline for everybody in every health situation anywhere. But having him tell us, this can make such a difference to someone like myself. This could literally be the difference between life or death. And so the key takeaways before we open it up, gender is complex. This is really just scratching the surface, but making that effort to use inclusive language can make everyone feel more comfortable, not just transgender people, but everyone. But when we talk about the transgender community, like it's not all gloom and doom. I know we talked about some very heavy topics, but the community is diverse and resilient and beautiful and, just incredible, but has a very hard time finding welcoming, affirming healthcare that should be a right for everybody. And so what we can do to help reduce those inequities is create that more welcoming, inclusive environment wherever we are in the system, right? We don't have to be direct patient care providers. And if you're in the research world, examining the design, the methodology, the questions that you're asking to ensure inclusivity for transgender participants. And my little side plug is just do more research on transgender health. We need it out there. So I so appreciate this opportunity. I know I've talked a lot. I know it's a lot to take in. If you are eligible for CME or CEU credit, we can put those links in the chat, and I believe Karen can send them out separately as well.
All right, Lindsay, I think we can finish off here. Thank you so much for coming. Thank you for sharing all your experience and your knowledge and your care, how much you care for this. It's so obvious in how you express yourself and how you've talked to us.
My
so thank
pleasure.
You so much.
Asman, I just want to remind everyone again, it's like, practice those pronouns, practice using singular they. Here's your action item, your homework.
Right. Thank you, everyone. Thank you, everyone who is here. And again, everyone will receive the recording of the session. And please answer the survey that Karen has posted before you leave. Thank you, everyone. Bye-bye.